Hello, my name is Gloria Donnelly. I'm the Dean of the College of Nursing and Health Professions here at Drexel University. And I'm going to discuss with you today the evolution of the healthcare system and your place in it. The name of my presentation is Not Your Grandmother's Healthcare System. And my grandmother lived in an era where all of her children were born by midwife, with midwife assistants, all 14 of them, where not many people were admitted to hospitals. That was the early 1900s, where if you really needed nursing care, you called a private duty registry. And so then we moved, let's start in the 1940s and 1950s. This was pretty much, I think, a great icon for the nature of the healthcare system in the 40s and 50s. Cherry Ames was a nurse who was immortalized in a book series written by, of all things, a social worker who had a real feel for what was going on in the healthcare system at the time. I read all of those books when I was a young woman, which probably inspired me to enter into a healthcare profession. And so you see in these books, Cherry Ames is a student nurse, and then she's a senior nurse, and then she went on worldwide adventures. She was a cruise nurse. Employment in this area is still available today. She was a department store nurse. And I can remember as a child going to Wanamaker's department store in Philadelphia and getting sick on the little toy train at Christmas time after I saw Santa Claus, and being taken care of by the wonderfully competent, starched, and very lovely department store nurse, which was really occupational health nursing. And then, of course, my favorite was Dude Ranch nurse. Now, I don't know if there were nurses on Dude Ranches. It's still a goal of mine. Next slide. This is the way we dressed back in the 50s and 60s. These are student nurses from Villanova. I'm in the front row. I was one of those pioneer nurses in the 60s who decided that I would get a bachelor's degree, attend a bachelor's program instead of a hospital school program, which were dominant during that era. And so we had very symbolic uniforms. This picture was taken on the steps of a hospital in West Philadelphia, where we did a lot of our clinical. And back in those days, our clinical experiences were primarily in hospitals, but they were also very heavily public health focused. So we wore navy blue uniforms when we did our public health nursing experience. We rode the bus, we carried a black bag, we visited homes, because there was a very, very sophisticated public health network in the cities where public health nurses received referrals from hospital emergency rooms, from city health departments, and we did things like visit homes where children had not been immunized, or we visited the homes of individuals who had shown up at the emergency room with poisoning experiences. We inspected the homes, we took care of the elderly in the homes, and generally we did a lot of assessment. And then all of that went away. There's no more home visiting by public health nurses, and public health nurses are very few and far between, and they work primarily in administrative roles in health departments, and those positions are really not available. Now, community-based nursing clinics and interdisciplinary clinics have evolved in the last 2 decades, but that is very different from the focus of public health nursing. So what is really changing healthcare today? We are in the midst of a huge change in healthcare. And I've lived through about 40 years of changes in healthcare. It was simpler times when if you got sick, you went to your doctor, doctors made house calls, you were admitted to a hospital if you needed to be. Your hospital stay might be a week or 2 weeks. You might have to go to the hospital back in the 50s or 60s to even get a diagnostic procedure. And that has all changed because of technology. And so now, if you need a diagnostic procedure, you go to a diagnostic center. It may or may not be in the hospital. When I was a student in the early 60s in hospitals, I would say 20% of the patients that I took care of were there to get some sort of diagnostic test. Some of them stayed and had procedures done, but many of them went home because the diagnostic tests turned out to be negative. And so now, all of that is outside of the acute care setting. When I was a student in the 60s, acuity in hospitals was nowhere near what it is today. And when I was a student, there were some professions, health disciplines, that did not even exist, like physician assistants, like many of the mental health professions that now do grassroots mental health care in community-based settings. And so not only has the healthcare system evolved, but even the number of disciplines that offer care has evolved. Technology has had profound changes in healthcare, and the electronic medical record, robotics, sophisticated diagnostic testing that can all be done virtually. And more is coming. Here at Drexel, we have the Excite Center, which is working on some very sophisticated projects. For example, we have a project, a collaboration with a physician in the College of Medicine to design a belly band for pregnant women to wear that detects premature contractions. We are looking at developing a little onesie for an infant to wear that detects the kinds of conditions that may lead to sudden infant death. And so technology and all of the health apps and calorie tracking and movement and exercise tracking is really factoring in a very, very big way to how the healthcare system is evolving. Cost containment in healthcare is huge. We know that there's a great deal of fraud and waste in healthcare. There is tremendous efforts to contain healthcare costs, and that's going on by insurers. Healthcare costs are shifting, and the whole healthcare system seems to be moving from an acute care focus to a health promotion and self-care focus. Consumers are very interested in health, and I think the internet has revolutionized healthcare. Last night I was reading an article about how Google in 2009 was more successful than the Center for Disease Control at predicting where the flu would move next by the way that their consumers were searching the internet and looking for information on the flu. So we are living in an era where big data is driving information to us that we never dreamed possible before. We were, back when Cherry Ames was a nurse, there were nurses and there were physicians and there were other health providers, but pretty much there was a hierarchy of healthcare personnel with a physician as the captain of the ship. Today, we work in teams. At least we try to. And the captain of the team is determined by the nature of the problem. And so interprofessional communication, interprofessional education is really what is needed to prepare the health professionals of the future. Safety and adverse events is a huge issue in healthcare today. We know from the Institute of Medicine's report in the late 90s that upwards of 98,000 people in this country die every year of adverse events in healthcare. Mistakes in hospitals, medication errors, procedural errors. And there has been a huge push to do something about this. We have much more regulation than we had before. I sit on the hospital board, and we spend at least half of every hospital board meeting talking about the core measures. These are the measures that the Center for Medicare Services collects data on from every hospital. So we look at the rates of ventilator-dependent pneumonia or decubitus ulcers or a whole range of measures which must be kept very low in order to provide good care and safe environments for patients. And then there's the politics of healthcare. Who are the big players today? Pharma, hospital systems owners, systems of health, systems of the health industry, rehabilitation centers, gyms, weight loss centers, and we should extend this out to organizations that are working on nutrition and diet and obesity, which is one of the biggest problems in this country. And then we have the move to self-care. I know when 10 or 15 years ago, you could not go into a restaurant and see caloric value listed on any menu. But you can today. In fact, it's very common because there is a whole philosophy called benign paternalism that says if you give people information about decisions that they need to make in terms of their health or health care or nutrition, if they have enough information, they will be nudged into the right decision. And so I'll give you an example of that. My husband and I were at the airport one day, and we were not going to have lunch on the plane, so we ran over to a kiosk, and I reached for my favorite sandwich. But I saw underneath on the bar 610 calories. And my hand snapped back as if I had just been burned. Now, I'm a health professional, I'm a nurse, I'm a psychologist. I had no idea that that sandwich was 610 calories. So I went down to the other end of the kiosk and I found one for 250 calories. And that's a great example of a nudge. So what we're trying to do in this country, in this era, is provide more information so that people can make more informed choices and then hopefully stay healthy. How many more drivers can you name? you work in healthcare, or you may have relatives who work in healthcare, or friends who talk to you about all of the things that are changing in healthcare. And this will continue as the Affordable Care Act continues to roll out, as the healthcare system shifts from more acute care to ambulatory care, as the United States grows older in age and more chronically ill instead of acutely ill. This will create massive change in healthcare. Next. This is another example of how technology can possibly change healthcare. This is a system that was invented by a group of people up at the University of Washington, and this is Penelope, the first assistant operating room nurse, a computer or a robot that hands instruments and records when those instruments go back into the queue, so that nothing gets left inside the patient, and it's a very efficient way. So this is Penelope, and this is the future of healthcare. Let's look at what we spend in healthcare. Hospital care gets over 30% of the entire national healthcare expenditures. I think if we looked at this chart in another 10 years, and you can see now that in the United States we spend about $2.5 trillion on healthcare, we will see a different quadrants in the pie, different shapes. I think hospital care will probably shrink. We will see more in ambulatory care. We may see more in pharma, as new prescription drugs come on the market. Home health care. My prediction would be that home health care and nursing home care will rise dramatically over the next 20 years because of the aging of the population. So this just gives you, I think, a clear sense of where the United States spends their healthcare dollars. And it gives you something to think about in terms of the impact of the changes we've been talking about. This is an interesting slide that comes from Porter and Teesberg's book on redefining healthcare. And through several meta-analyses and studies, they have discovered that patients don't always get appropriate care. So there's a standard of appropriate care, and then there's the delivered care. And you could see there is a tremendous gap in counseling and education, which may be a function of the fact that the healthcare system moves very speedily, that time is money, and that we often don't spend enough time giving patients the counseling and education and health information that they need. So if that gap closed, let's say by 50%, what would the healthcare system look like in terms of outcomes? So this is an interesting thing to think about as you frame this against all of the changes going on in healthcare. The cost of waste, fraud, and abuse in healthcare in this country is enormous. We spend 30% of our healthcare dollar on administrative costs, but 3 to 10% of healthcare spending is accounted for by waste, fraud, and abuse, estimated to be anywhere from 67 to 230 billion annually. I think, however, we are living in an age where the detection of waste, fraud, and abuse will become easier and easier because of the enormous computing power that we now have, and because we can now look at big data and detect patterns of waste, fraud, and abuse. Next. Those of you in the audience who might be nurses, remember the evolution of the way we designed and delivered patient care over the years. So let's say from in the 1930s, in the early 20th century, if you were a nurse who worked in a hospital, you had X patients, you maybe had 10 patients to take care of per shift. And so you went in, and let's say you worked on the day shift, you were assigned 10 patients, you took care of those patients. You may or may not have had some help, some assistive help. And that was called total patient care. In the 1940s, when World War II was happening, many nurses went into the military. And a new methodology, a new way of delivering hospital care had to be designed. And so functional nursing came into play. And I remember in the 60s, there were some healthcare settings that students were placed in and that I went to that still had functional nursing as their delivery model. It was a task-oriented model. It was kind of like an assembly line model. So you had a nurse manager, you had a medication nurse that delivered all the medications all day long, and you had a procedures nurse who did dressing changes and other kinds of procedures that were ordered for patients. But patients were not assigned to individual nurses as they were in the 1930s. That seemed to work okay, but in the 1950s, there was a nurse up in Minnesota by the name of Thora Crone who said, you know, we really need to have a multi-level nursing team. And team nursing came into effect. And her iteration, her design model was that nurses, particularly those who were the leaders on the team, should really have 24-hour responsibility for patients. And there needed to be better coordination across shifts. So you had an RN or several RNs, you had an LPN, you had nursing assistants who were assigned to so many patients with 24-hour responsibility. 1960s, primary nursing came into play. The war was over, there were plenty of nurses around, and hospitals moved to the all-RN staff. That actually is going on today. Next slide. In the 1980s, we had patient-centered care. I don't know what other kind there is, but it was a new phrase where the patient and family were the center of care. There were patient care coordinators who were registered nurses and patient care associates, and it was really a system designed to be more efficient. It was to improve quality, decrease cost, but primarily increase efficiency. And now in this more modern era, if we go to the next slide, we are now working in a system that is encouraging relationship-based care, which has a triple focus. So you have the care provider relationship with patients and families, the care provider relationship with self. So this model really encourages that the nurse or the physician assistant or whomever the care providers are, either inside or outside of the hospital, take better care of themselves. And then the care provider relationship with colleagues, which means increased respect, better communication, interdisciplinary collaboration, which we know from tons of research improves the quality of care and staff satisfaction and produces much better outcomes and fewer errors. Next slide. Think about your own practice arena and all of the mistakes are made. And any place you work, there are errors, because wherever there are humans, there are errors. So in your workplace, do you get regular reports on the number of adverse events experienced by patients? Do you sit with the group and really look at the patterns? Where, when, who, the type, the impact on the patient? How do you believe knowledge about adverse events should be fed back to improve practice? And what are the most common costs of adverse events? These are things that you should be encouraging and actually pushing for in your own workplace, because you really cannot improve the environment of safety without having the information that you need about the occurrence of adverse events in your own institution. Next slide. So what do we know about the reporting of adverse events from research? We know that the Department of Health and Human Services in 2010 tells us that hospitals did not generate incident reports for 93% of adverse events. And of the events that were reported, 63% were inaccurate. That only 1.5 of all adverse events produce an incident report. Now we have to go in and look at how are adverse events defined, how do you define them in your own practice, in your own institution? And shouldn't we be focusing more and paying more attention to those, I call them little errors, that occur that can lead to more serious consequences for patients? The American College of Surgeons, for example, estimated that only 5 to 30% of adverse events are described in incident reports, and a general surgery study asserted that only 20% of surgical complications are discussed in mortality and morbidity meetings, which are those meetings that physicians attend who are practicing in hospitals as they review the issues around mortality and complications in the hospital practices. Next slide. I think it's important for us all to keep in mind what the leading causes of death are in the United States, because they keep changing. And I think I need to point out that Alzheimer's disease is now the sixth leading cause of death in the United States in 2010. I would predict if we had this hard data for 2014, it would have moved up considerably, because with the aging of the population and knowing that Alzheimer's is really a terminal disease because there is no intervention yet that stops the disease, the progress of this disease, Alzheimer's will be moving up this list over the next few years because we live in an aging society. Many of these conditions are conditions of lifestyle, diseases of the heart, cancer, lower respiratory diseases, which is of course about smoking. Stroke is lifestyle related, and of course so are accidents. Diabetes is nutritionally related. And I won't go through the whole list, but you get the idea that changes in lifestyle, more attention to exercise and nutrition can really shuffle around these leading causes of death in the next 10 years. Next slide. This is Virginia Henderson. She's a heroine of mine, and back in the mid-20th century, Virginia Henderson said to the nursing profession, wake up. What we need to do in nursing is begin looking at the effect of nursing care on patient care outcomes. Not looking at what nurses think and their perceptions and their attitudes and how they feel about their roles, but let's look at what nurses do and what effect nursing care has on patient care outcomes. And we are still in this mode. And so I want you to think about Virginia Henderson, a pioneer in nursing, because often we don't highlight our heroines in many of our health disciplines very much. But she said, operationalize nursing care and let's show folks what the outcomes of good nursing care could be. Florence Nightingale, let's go all the way back further. She had a hunch. It was so simple. Her hunch was, if she went to the war hospitals in the Crimea, which incidentally is a world hotspot this very day, but if she went to the Crimea and she just cleaned up the hospital, the war hospital wards, just removed the awful trenches of waste, if she changed the soldiers' dressings, if she bathed them, then she could reduce mortality. And she reduced it enormously in an era where germs were just a theory. So Nightingale had a hunch that hygiene would improve patient care outcomes. And she proved it with statistics. And every one of us who move about in healthcare every day probably has a hunch. And so I'm asking you, what's yours? And how can you really investigate it or study it in a piloted way to improve patient care, not only in the hospital, but in the home, in the clinic, wherever you are as a practitioner. So what did these nurses have in common? And there were many health professionals. I'm not restricting this to nurses. I'm thinking of a physical therapist on our own faculty, Bob Palisano, who developed a scale to determine the functional ability of children with cerebral palsy. And that scale is used all over the world. I'm thinking of a couple and family therapist, Dr. Guy Diamond, who's a member of our faculty, who is a world expert in suicide prevention in youth and has been recognized for this over and over again. I'm thinking of our dance therapists and our music therapist, Dr. Yoka Brad, who is working with patients with chronic pain and training their voice in order to manage chronic pain. So what do these folks have in common with nurses like Henderson or Nightingale? They're daydreamers. They have visions of what might be on a local level, on a grand scale. Their ideas usually go against the grain. They imagine what they could do in the era where they're practicing, and they do it. They do something. They siphon criticism. In other words, they listen to criticism, and if they could use it to improve, they do. If not, they discard it. People that make great change in healthcare have thick skin, and you have to in this media age. The people that I'm referring to are persistent doers. They love to work. They don't settle. They're always in pursuit of excellence. And they think about their, quote, stuff all the time. And most of them In fact, all of the ones I mentioned to you, the folks that are here in the college today, and Henderson in mid-20th century, and Nightingale in the 18th century, they didn't care about personal prestige, but rather about spreading the word of their work. They wanted to improve practice. They wanted to improve outcomes. They wanted to improve society, and they did. So, let's go to 2012. We know from statistics that were produced in 2012 that 50% of the U.S. population utilized hardly any healthcare services at all. 10% of the population consumes nearly 2/3 of all healthcare spending, and that is usually hospital-based care. And then chronic conditions consume 2/3 of the healthcare budget, and that's cancer, cardiovascular disease, and diabetes, all diseases of lifestyle. And so the goal has become, no matter what you read, reducing ER use, reducing hospitalization and readmission rates, and reducing the use of specialists by focusing more on disease prevention, on chronic illness disease management, and on health promotion. And who will be key in this role? Advanced nurse practitioners, physicians' assistants will be the disruptive innovations. Now, will there be sufficient numbers of these advanced nurse practitioners or physician assistants to implement the plan to meet the demands of this year, of the next 10 years? How will the role, for example, of an acute care nurse practitioner evolve? And what about the clinical nurse leader movement? Will that persist? What about the nursing faculty shortage? Is it going to interfere with the production of high-end, mid-level practitioners? And these are the kinds of issues that we're struggling with in higher education today as we attempt to meet the needs of this evolving healthcare system. We know currently that in 22 states in the United States, nurse practitioners can, quote, hang their shingles, independent of physicians. And these states are usually rural states, although Massachusetts, which is not a rural state, is one of them. This is probably going to be the trend for delivering primary care in the future. There are many, many studies that say that nurse practitioners and physicians' assistants will probably be the major primary care providers in the next 50 years. And we know that physician assistant programs are proliferating as well as nurse practitioner programs. And this is all in terms of meeting the demands of a changing healthcare system. So advanced practice nurses and physician's assistants are simpler, less costly to use. If you look at minute clinics, look at convenient care centers, nurse-managed community-based health centers. These disruptive innovations take root where institutional and regulatory barriers can be minimized. The disruptive innovation model is a more for less model. And there are tons and tons of studies that say that the care delivered by mid-level practitioners, by advanced practice nurses, by physician's assistants, by physical therapists who are licensed in their own right, by mental health practitioners, like the music therapist and the couple and family therapist and the behavioral health counselors provide a more effective strategy with greater outcomes, which is more cost effective. Next. Now my message to you is what we need to do is relinquish stupidity. There's an awful lot changing. Change is really hard. And stupidity really has nothing to do with how smart you are, how long you went to school. It's the inability to adapt your own headset to the ever-changing contingencies of reality. And if we get too nostalgic about the good old days, we will have tremendous difficulty in meeting the needs of society in this changing healthcare system. So I am asking you to think about stupidity and relinquish it. Next slide. This is pretty much the way healthcare delivery has changed over the past 3 decades. We've gone from episodic care to ambulatory care. We're going from a focus on how many times you visited a health provider to what actually happened there, to the value orientation. We're looking much more at analytics and data mining, and we're trying to increase safety by reducing adverse events. Next slide. So, what does all of this mean for you? And what does it mean for me? What it really means is that we're in charge of our own future individually, but we are caught up in a rapidly evolving healthcare system. So my advice to you is do something. Do something different. Follow your hunch. Try something. Look at a problem in your institution and try to fix it. Get hooked on problem solving. I know this is going on in many, many hospitals, for example, where the nurse leadership is looking at data across patients, across patient care, is looking at how many times people fall in the hospital and when they fall and who was there and why they fall, and then tweaking the system to prevent events like that. Get hooked on that problem-solving activity. It's really what professional practice is all about. And remember that even chaotic action is preferable to being neat and orderly but inactive at all. We have a penchant in healthcare for wanting things to be neat, orderly, and process-oriented. But we're living in a time that demands very, very new action. We need to solve problems. So experiment with your ideas and make a difference. And please let us know how you're doing. We would love to hear from you. Thank you. There were too many